Well, hello, good morning. Welcome to you all, to everyone here in the room at Bad Hofgastein, and to everybody who's joining us online, welcome to you all. And for those of you who are in the room, perhaps some of you were at the gala evening last night. Shades of the Desert, I think, was the theme, but perhaps maybe this morning, shades for your eyes for a few of you. But look lively. I'll make it an easy first question, and just to get your brains ticking, what would you say is the greatest burden of diseases in the EU, representing 80% of the burden? Now, those of you who've looked at your app, read the program, will know 80% of the burden of diseases in Europe come from chronic diseases. The non-communicable conditions like stroke, heart attack, diabetes, COPD, cancer. And so in this session, we're going to be discussing why tackling chronic disease is a priority for Europe and restating the case for investment in health. My name is Sue Saville, former medical correspondent at Britain's ITV News and now an independent healthcare communication specialist. And we very much want interaction in this session. We want your questions. Now, when we come to questions, you can raise your arm in the room. There'll be roving mics. If you're feeling a bit shy or a bit jaded this morning, you can go onto the Slido. There is a QR quick response code there for you. And for those of you online, please do submit your questions as they occur to you, because we have the lovely Josephine Mossad, young Gasteiner, over at our news desk, and she will be looking through the questions and getting the key themes. Comments are fine too, so please do submit those as we go along. But to set the scene about chronic diseases, and before I introduce our fabulous panel, let's firstly take a look at this short video.
In 2023, the EU lost far too many lives to stroke, heart disease, COPD, diabetes, and breast cancer. That's equivalent to the entire population of Barcelona lost to 5 chronic diseases. And by 2050, the number of lives lost every year could reach 2.2 million, roughly the population of Paris. But it doesn't stop there. On top of the staggering costs to life, chronic disease also brings enormous economic costs to our societies. In 2023 alone, these 5 diseases cost the EU about €530 billion, equivalent to 3.13% of the EU's combined annual GDP. Given Europe's strained health budgets and financial pressures from so many other challenges, this is simply not sustainable. Now let's imagine a different future. A future where we manage the rising tide of chronic diseases better for Europe's patients, healthcare systems, and societies. In Portugal, investing in better diabetes control could prevent over 1,100 cases of retinopathy and over 350 amputations each year. In Romania, scaling up care for cardiovascular disease could save more than 107,000 lives by 2050. Not only that, for each €1 spent, at least €1 is returned directly to the economy as people can stay in the workforce, meaning that the investment pays for itself. That rises to as much as €11 if we consider the full societal value. And in Sweden, providing comprehensive breast cancer treatment to women could return as much as 5 times the initial investment directly to the economy. Just imagine how many more people we could help live longer and feel better by better managing chronic disease in Europe. Imagine using those savings to invest in new breakthrough technologies to treat and cure cancer and rare diseases. Imagine improving mental health care services for our loved ones. Imagine funding the green transition of our societies and financing a stronger, more secure Europe for generations to come. We've imagined. Now let's take action.
So let's take action, and those who know what actions need taking are our fabulous panel. We have Nathalie Moll, who is the Director General of EFPIA, the European Federation of Pharmaceutical Industries and Associations. I always run out of breath on that one. Pedro Facon, who is from the Deputy CEO at the Belgian National Institute for Health and Insurance. Stefan Eichwalder, who is at the Austrian Ministry of Health and Social Affairs, Director of Health Systems. Julia Mada, who has two hats. She is with the European Association for the Study of Diabetes, also an associate professor of medicine at the Medical University in Graz, and Joachim Ramsberg, who is the head of science and policy at the Swedish Brain Foundation. Welcome to you all. Please, a round of applause to get them woken up. So, Natalie, first, your organisation, EFPIA, brought this topic to the forum. Investment in health is something that is often considered. It's been touched on in other sessions here too. So why did you particularly want to focus on tackling chronic diseases?
So you said...
Grab a microphone.
You said it in your opening, so 80% chronic diseases is responsible for 80% of the burden of Europe's disease, and you saw it in the video, the impact that it has, and we still haven't got it right. So that's why we brought it back. I think that just in the few minutes before we started the panel, we had a conversation amongst us, and just in those few minutes, I learned things I had no idea about, and I would think like after half a century, I would know some stuff, but I really learned some fundamentals that make it very logical for us to sit here today, and not just today. Because this is obviously an enormous mountain to climb, being here in Austria. We all know that reducing or cutting health expenditure is not a good idea. We've all been saying this, and yet as the pressures mount, especially in the current context where Europe is facing wars, is facing a declining competitiveness, a declining economy, I don't think you immediately think I must invest in health. And so the idea is really to bring to the fore the weight of what chronic disease represents in terms of burden on the European economy, and then the case for investing in it to find the solutions that will make the difference now. So it's a little bit of competition, but also a little bit of bell ringing, there is a case to do it now, and then most of all, getting together and finding solutions, because it's obvious that no one sector has the solutions, no one actor has the solutions, and not even the knowledge. And I think that is really, for us, incredibly valuable to start with this panel, but possibly to continue in the course, at least of the next 5 years, with the new institutions, to really bring to the fore the need to invest in healthcare, especially in the area of chronic disease, and that will actually result in solutions for the other challenges that Europe is facing.
And you touch on the competition. I'm interested from a national perspective, both Pedro and Stefan, perhaps from your perspectives, you've got national competency on funding for health, but how do you then manage that, where you know that you've got a huge amount of demands on your budgets, but you've got to try to focus on really something that in the longer term. Pedro, how can you make your health system more sustainable by tackling these longer term issues?
Well, I think we are heading a little bit in the perfect storm for our health systems and financing of health systems, because on the one hand, we can see, for example, in the forecasts of our Central Planning Bureau in Belgium, and it's the case for many Western European countries, that the aging is really getting at its highest speed in the next 10 years. And it will go on for a few decades, but the pressure only from aging, but also the growing of the population, also innovation, etc., is putting a lot of pressure on the healthcare budgets. There's a clear upward pressure on the healthcare budgets. On the other hand, it's very clear too that when it comes to the macroeconomic situation, when it comes to competing dossiers and topics that the governments need to deal with, that somehow healthcare is maybe a little bit less a priority than before, or not the sole priority. And I think that we need to be very aware of that. So on the one hand, and I often say that I feel a little bit like schizophrenic. I know that there are medicines for that too, or there are medicines on their way, I've read. But on the one hand, we really need to, towards the external world, not the people of the healthcare system, make the case for investment. Make the case for investment. And the analysis we saw here are really important to convince ministers of budget and other actors in society that we need to invest in health. But on the other hand, and that's the other part, inward in our system, everyone here around the table knows that there's a lot of waste and that we could turn the money we spend in our health systems much more into value than we do today. Often we are talking about investing new stuff that we want to introduce, but 97% of the budget, like the benefit basket that exists, is often not touched upon. And it's there that we also should improve efficiency, improve the value. So we need to work on that, and it's a priority.
Thank you. Stefan, is the waste here in Austria in your system that could be better utilized to perhaps tackle chronic diseases?
Yeah, good morning also from my side. It's funny because maybe I can share that we also sit next to each other in the health committee, in the OECD health committee, and it's very, very timely discussions, and we also bring it much to the health committee in this combination and macroeconomic, to add this macroeconomic view. I will come back to the waste, no worries, I will definitely go into that one, but I really want to add in the numbers, and I think this is an important step, because it's the aging that was discussed. I think we will have 430 million people 80 plus in 2050. So that is a 300% increase only in the last 20 years. So this is wonderful. But again, it also we need to change ways of working. And we will have the impact of climate change. We will have so many other aspects that are challenging us in the way we can ensure the sustainability of the healthcare system, but also the fitness of our healthcare systems to deliver where it's needed. And the last was in August, and that was really shocking for me, this Lancet Psychiatry Commission, and many of you might have read it, but it's with the globally, the mental ill health, with a 45% burden of disease in the age group of 10 to 24-year-olds. So it's really the young generation, and this is where we also need to focus if we have this future-oriented look, right? And this is why I would also agree, and this is the two heads, and I was on a panel on Tuesday on the EU Health Investment Hub that we lobby for, because we think we need more. But at the same time, the argument, I think, particularly with our colleagues in finance, is a lot between spend better, versus spend more. And I think we cannot make the argument for spend more if we can't first fix the spend better, and that is coming back to the waste. And definitely, I mean, there are studies about waste, and we can discuss the different methodologies and numbers. I'm not so much concerned about the waste of today. I mean, that is also here, and that is something we need to tackle. But I'm really concerned about the waste of tomorrow, because if we don't adapt, that will become even worse. And we have some projections that if we don't change the service delivery mix, we are so inefficient that it will cost us so much more money just keeping the status quo. So not getting better, but just keeping the status quo, and it will not be sustainable. So it's really particularly the waste of tomorrow that is I think where we need to look at.
Thank you. And there have been some amazing statistics already. Julio, with diabetes, it's some 60 million people in Europe who have that condition. So from what you know and your expertise, how would tackling a long-term condition like diabetes make a difference to healthcare budgets and wider society?
Well, so diabetes is a chronic disease, as we all have learned. One of the big problems still is that it's underdiagnosed and under-recognized. So health literacy is one of the topics. So because you do not feel diabetes upfront in many cases, so specifically type 2 diabetes can be a very silent disease for a long period of time, so that people might seek help of a physician only when it's too late. So for example, when they have issues in vision, when they have kidney problems, when they have lesions at their feet. So, and only then diabetes might be diagnosed. So we need to improve health literacy. That can be happening already in schools, so that we really train people to seek help on a routine basis, also to pursue a healthy lifestyle upfront. And of course also, as we heard, the diabetes itself, the treatment is of course costly, but the complications contribute way more to the cost than treating the disease. So one of the big issues is that you have to challenge health insurance budgets in many cases to provide better technology, better treatments. But on the other hand, you would save so much money. So I think this is one of the big gaps where we have to convince our payers and our politicians to make funding available upfront, because it's an investment in a healthy future.
Thank you. We hope in this session to come to some really lovely, pithy solutions. But before we get there, Joachim, can you just outline some of the challenges to getting to that greater investment? There are so many issues along the way.
Yes. That is, of course, I mean, it's an extremely difficult question, and I guess your hypothesis will be just as good as mine. But I wanted just to mention three different things that I think are important, and one is actually that, often brought up that politicians are so short-sighted, and that's an easy win in a debate many times. But I'm not convinced about that argument. I think to some extent it's just, it's another way of saying that politicians are human beings. I think, as humans, at least I know that I'm probably hardwired to have some sort of time perspective. And you could also, I think, over time and on average say that politicians, they take the time perspective that their voters want them to take. And so I think that's not a very good discussion to be having. But, the second thing I wanted to bring up is that this actually is an extremely difficult question relating also to the time aspect, that these are very complicated diseases like diabetes, for example, with, risk factors and processes that starts many decades, sometimes before the actual symptoms of the disease are visible, and the effects then go on for decades after that. So it's a time perspective that is difficult to handle, and it has effects all over society. And and they're also extremely prevalent and very, very expensive. So, Stefan, you brought up mental health, and looking at brain disorders as a total, the cost to Europe alone of that is 1 trillion euros per year. I mean, it's staggering. It's hard to believe. And it's important to note that, and most of that is chronic diseases. And it's important to note that about half of that is actually direct costs. And so that is money that we're already paying for those diseases. And that leads me to my third point, that there is no, I mean, as already been brought up, there is no shortage of other important things to invest in. And it's a hard ask, actually, to say that now we want to spend and invest even more on these diseases that are already so enormously costly. And then, with the time, quite uncertain outcomes long time into the future, it's difficult to manage for anyone. And just to get, an example that might sound trivial from Sweden is that we underinvest in the maintenance of our water and sewer systems in Sweden. So every year we would need to spend 50% more than we do. So we have an accumulated deficit in the maintenance of an infrastructure that I would say is probably as important for public health as healthcare. It's like we can't really afford to lose our clean water. So it's and that's just one area. I mean, there are any number of issues to discuss. So there's fierce competition for budgets. There's also fierce competition for attention. For these issues, of course.
And that's really important, isn't it? Attention. Yeah. It's perhaps like we say about justice must be seen to be done. Investment must be seen. Yeah. And Stefan, looking at that, the longer term issues, how can you make sure that things like, as Joachim mentions, clean water, things we take for granted that aren't upfront and big wins for the politicians, how can you make sure that the longer term investments are there to see that the investment is seen to be done, that we really see the value to society?
Thank you. There was a smile with some of the people in the audience, because we do have a problem in one of the biggest cities in Austria with water at the moment, because the infrastructure is too old, and now they have to use plastic bottles and filled water. But this is why the example was so timely. And to be honest, it's painful. Coming back to Gastein year after year is more and more painful, because it's not the evidence that is missing, right? It's not the knowing what we should be doing that is missing, but it's so difficult to implement. And this is why we also see that we need to really find new ways in the discussion. I'm a bit afraid that with the term investment, particularly with our friends and colleagues from the finance sector, that is sometimes misleading, because for them an investment is very clearly defined and is something different. So I'm a bit sometimes I'm not sure if we are too much between ourselves and then the people on the other sides, they simply don't understand us, and also our data and our numbers are not striking enough. I mean, for us it's shocking and striking, and then I learned that the hard way, because I was implementing a project with the European Investment Bank, and I had a meeting with the people there, and they asked me all these typical bank questions, and we were not prepared. So I think there is something to learn, and this is also what we push for in health ministries, to also develop this capacity to have that a better instrument and set. And what we also see as regarding the long-term trend, we really need to be very careful when we look at the estimates of the revenues and the expenditure in the healthcare system, because very quickly we see that we saw that after the financial crisis, it can very quickly shift expenditure to the private sector, to the private households, and we know that then financial hardship hits very hard, and it hits the poorest, who really then are brought into poverty, etc. And I think we need to make sure that this is not happening, but we have mechanism in place then to protect. So this is exactly this long-term view that we need to follow, and to adjust our health systems.
Thank you. And do keep those questions coming. If you'd like to put any comments about the water system in Austria, that's fine. We'll come to Josephine shortly. But just Pedro, picking up on a couple of points there that Stefan made about even the language about investment or cost budgets, with your role in the health insurance of your country, how important then is it to get the language right and to get the understanding, the communication about budgets and about what cost is? Because otherwise people will just see up front that's the cost. But to take those wider points, have you got the tools you need to make the case for investment?
Well, I think that on the basis of what we are trying to do with clear health objectives that try to be oriented towards improving our society and conditions of living and health of people, that is already a good compass to orient some choices in the healthcare budgets there. When we make choices about new reimbursement for medicines or for new technologies, if we do HTA, then it is because we want to see what is really the cost we want to pay for the value that it would bring. I think that should be generalized to many other domains of the healthcare budget, because to be honest, the analysis of reimbursing a new medicine is done in a much more thorough way than, for example, the introduction of new service models or new financing models or a new technical act of healthcare providers. So I think this should be kind of generalized. But what I would like to build a little bit on what Stefan said, and this mild depression I can feel a little bit of having to come back every year, and also in the health committee, and feeling the same way. It is really hard to change things. That is because between an health economical analysis to see if you would do this, then it could give that value or that return. These kinds of models are obviously full of hypotheses. And what we see is when we need to implement things in the healthcare system, that a series of these conditions are not filled in. If we want to make an expenditure into an investment, then often there are a series of conditions with the health workforce or with healthcare providers or care processes that should be adapted. Otherwise, it's just an expenditure and not an investment. And I will give you one or two examples. We have made huge investments in digitization and digital infrastructure in our healthcare systems everywhere. You do not want to know the billions we spend with individual healthcare providers and hospitals for creating this digital infrastructure and making it possible to having electronic health records. But what is the value we are getting out of this today? There are a series of reasons why it's not coming yet, and that also shows that if we just continue to spending in it the way we are doing, we will never get the value out of it, and there are reasons why we don't get the value out of it. We also see that, for example, when it comes to care pathways, we had a good success with diabetes in Belgium, I think, starting from detection to all kinds of care pathways we introduced. That worked well. But what we see is that, for example, for care for obesity or for other wicked problems, that often when we want to introduce a new care pathway, we are touching upon existing business models and income. And it's then that some healthcare providers say, well, on paper it's perfect, but I will gain less, or I'm just not interested, I'm happy with the way I'm working. And that's why we are not able to turn something that on paper could give a lot of return. We are not succeeding in turning really into value because we are coming into a system that is existing with all kinds of existing business models, vested interests, and it's hard to change that.
Unless, like in the UK, you say the NHS is broken and you set the scene for starting a new model. We'll see what happens there. But meanwhile, Natalie, from I'm wondering, beyond the national competences for this, is there a role for the EU Commission and its new existence? What could it do to try to address some of the issues raised there?
So it has tools, and I think you had somebody from DG Reform earlier this week. So it has tools that it can already use, like the structural funds. They can help with strategic investments in specific areas that are really targeted in their structural reform support programs. So these are things that it can already happen, but they're very specific. They might not be on time. There's also something that I need to read because I'm a scientist and not an economist, so I don't know anything about this. But earlier this year, the EU revised its fiscal governance rules. So it means that now member states can adopt long-term plans to reach EU fiscal sustainability goals. So it means that they can, if they invest in areas that are EU priorities like social and economic resilience, then they can do this on a longer-term basis without being told off faster by the EU. This is my scientific way of explaining an economic concept. And I think that is something really welcome because, of course, in health, as we just heard, it is a long-term investment. And I really like your challenge, Stefan, about the word investment, because you're right that this is our health community word, but and that's another thing the EU could do, give those economic analysis that would help demonstrate the case for health in words that are not our words, but the economic community's words. Because, the figures hit us, but when you bring it to the EIB or anybody else, they go, what? I don't understand what that means. And then you add to it what you just said, Pedro, about the incentives to do things differently are not really there. I wish we were like AI, and we learned and we adapted and we learned and we adapted and we learned and we adapted, but we're really not like AI.
That's coming.
So no, but as human beings, we're very much on, this is how I do things and this is how I get my money and this is how it works, and you want to change something, oh my God, then what?
Yes.
So there needs to be, I think, a conversation between the health, the ministers, the finance ministers. This is also something that can be helped at European level, putting health not just, and at the moment it's in 6 different DGs, so that's good, putting health not only in the health bucket, but also in discussions in the finance councils or other councils like that. That would be welcome.
And interestingly, Julia, in the EU Council then is currently discussing whether there should be an EU cardiovascular plan, perhaps taking responsibility. It is putting a budget on that. Would that work for diabetes? Is that an instrument that you think is helpful?
So for sure it is helpful for some aspects of diabetes, but it's not covering all. So if it is implemented, then we should definitely make a loud voice also for the field of diabetes. So either to be co-owners of that domain or having a separate pathway for diabetes. Because if we look into care pathways, it's in many countries the diabetologists taking care of the chronic disease and other specialities taking really only their tiny bits and pieces out of it that make money. Diabetes is a condition that does not really make a lot of revenue for the physicians, at least in the outpatient setting. So where you, like talking is never paid for. So interventions are paid, but talking, if you need like half an hour to explain something, there is really no big funding. And if we move that only to one disease area, I think we lose a lot of competency on the field of diabetes. And so either it should be co-owned or it should be two different pathways.
That's really helpful. Now, it'd be really lovely to get some voices from the room here and from Josephine. Let's just firstly take a couple of questions in the room. Lady with the green jacket on first, and then a couple over here. And I think we'll see, Josephine, what we've been getting in online as well.
Okay, thank you very much for that great discussion and the insights. And I have some comments for you.
Who are you, please?
I'm Birgit Bauer. I'm the project coordinator, Data Saves Lives Germany. I'm a patient expert, and I'm a person living with a non-communicable disease called multiple sclerosis. Not diabetes, but also one of those things. What I miss in the discussion, and I can understand that the question of numbers is so huge, and I can understand that we have to think economically because budgets are limited. I know that as a patient, I have just 7 minutes with my doctor each appointment. That makes not really fun. But at the end, we have to know the numbers. And I think we have, but we also, and what I miss also here in this discussion is prevention. We are talking just about the diseases, but can we also include that in the numbers, because prevention can help to be more economical? What I also miss in this panel, and unfortunately I have to say that, is the patient representative. You're talking about us, but not with us in this round. So you're very understandable, and I can see also your expertise and so on. But I would love to see also patient voice. So I'm doing this now. Also, one learning is because, and this is why I miss the patient voice. You can't walk in our shoes. You know the theoretic data, and you know what diabetes or MS is, but you can't walk in my shoes. And therefore, it's important to involve patients. And this is also investment. Invest in us patients. We can help. We have a lot of power. We have a lot of knowledge. We have ideas. So please ask us, talk with us, involve us, because we can also think economically. We have something in our brain. We have a profession.
Thank you. There's a lot there. What I'd love to do is to get some points from other people too. But you raised some really important points there. When we've taken a few questions, I'll ask the panel to pick out some to address, but you make very powerful points. Thank you very much.
Last point, communicate with us, explain it to us. Yesterday, Frank Vandenbroeke from Belgium gave us a great inspiration about communication. Also, he addressed this to the ministries. So please talk with us and explain it to the people. Then you have them on board, and then they will come with you. Thank you very much.
Very much. Excellent points. Gentleman here, would you introduce yourself?
Yes, hi. Boris Hazais from MSD. So I was wondering if, the question I wanted to raise is whether our health systems or budgets are fit for purpose in order to make an investment case. So basically, when you want to make an investment case, you need, as you mentioned, a time dimension. But there's also a budget dimension, meaning that when it comes to technologies, so pharmaceutical products, for example, they're eminently disruptive. I mean, nobody asks for a vaccine to prevent cervical cancer. Nobody asked for a cure against hepatitis C, but it arrived, okay? And there's a number of examples. But then it arrives, and there's a strong investment case as long as you design your budget accordingly. Right now, we're faced across Europe with annual siloed budget. So basically, it's, that's the money that's on the table for this year, regardless of what, the value that the new technology can bring next year and the year after and so forth. So you can't really make an investment case if your budgets are not designed appropriately. And so there's the time component, but there's also the integration component, meaning that, for example, Alzheimer's disease, if we are bringing finally treatments that will, delay the onset of the disease, then you really need to look at the interaction between the healthcare budget or the pharmaceutical budget and the long-term care budget. And right now, this is really not even, it's barely touched upon. So that's my question. Are those systems fit for purpose?
Fit for purpose, thank you. And we'll take one more question from the floor, and then I'll invite the panel to pick up those, and we'll come to Josephine. There was another question. Lady here at the front.
Yes, thank you. Giovanna Marsico, I'm from France. And the point for me is, of course, prevention. Prevention is the element missing in this table. And the second one is social gradients. We know from all the studies of Sir Michael Marmot and his teams that social gradients are indispensable to think about the future of health and healthcare. And this point the situation of health ministries in general, and I'm sad to increase your sadness, but health ministries, they usually have a position very weak in governments. I mean, health is not in every policies. Health should be in every policies. I mean, every policies should cross the question of health, and it's not the case today. So this is another question that we need to anticipate in order to assure that healthcare system will be correct in the future.
Thank you very much. Josephine, what are your two top questions that are coming in? Then the panel can pick up any one of those.
Thanks to, indeed, I was also selecting because the chat is quite live this morning. So the first one is, how do we deal with the catch-22, where investment is needed to gather data on a disease, but you can't get funding support without having this data? Second big question from the audience, are there healthcare systems that are doing it right? Are there any best practices that could be adopted in other countries to promote investment in health, especially in chronic diseases?
Thank you. Joachim, you were nodding on that. Would you like to pick up any one of those 5 questions?
They were so good.
So we're talking about the prevention very much was a theme. Yeah, patients at the centre, health at the centre of every budget of every ministry. We're talking about whether health systems are actually fit for purpose because they're designed for the current situation, not looking ahead. And indeed looking at the health analysis from data and there about best practices.
Yes, I'm going to try to pick up on a few of them. Yeah, the first one, poor communication. Yeah, I did that because I'm actually talking a lot about prevention. That's exactly what I mean when I say we need to invest in managing risk factors very early on and so on. And it's really hard to get the resources away from what we do today for the reasons that have already been talked about. So I think it's super important. And I think also the discussion also shows that it's the thing with investments in financial terms, that's a pretty strict and rigid thing. And we need to have also quite rigid and strict budgets to have any type of control over our economies. They need to be restricted in time and scope and siloed and so on. You can't just have one budget for the whole country and it goes on for perpetuity. It simply won't work. The money would run out like the first year. So we need actually to work within that constraint. And just not to quarrel with you at all, actually, just maybe to assure you a bit that looking at brain disorders, which I know the best, we know that 50% of Europeans have brain disorders at some point in their life. And everyone, not a single person on this panel is untouched by either on their own or in their families with brain disorders. I think, you can assume that pretty much everyone in here has lived experience either for themselves or with a close one, I think.
Thank you for picking up on
I'm trying to bring that perspective into every discussion, but I know I'm here in another capacity, obviously.
Thank you. So communication, absolutely key. You, Leah.
Yeah, I just wanted to add on the patient's voice. So at least from the projects that I'm working on, and that's, for example, projects in the field of diabetes, we, in all of the EU projects, do have a patient advisory group included, so the patient voice is definitely heard. And also many industries, specifically insulin-producing companies, do have also patient advisory groups. So they really want to hear the patient voice about novel developments, what is feasible for them and what is not. So sorry for not highlighting it here more and bringing it more to the table here, but at least be assured that the patient voice is heard. So that's very important.
Stefan, any of the points you want to pick up on?
Yeah, also starting, I think we will look and have to deal with tough decisions. I mean, we do it today already, and it might get even tougher because we see this shift of priorities on the global level and also on national levels sometimes. So when we also discussed the question of prevention, I think I heard it in every statement without the word being said, but this is partly, and I need to be maybe there was a bit misunderstanding. I'm not pessimistic. Yeah, I think it's really now time to implement. This is more the note that it would be important for me, and I would love to share some of the insights of how we try to do that. But in reality, if we also consider that the determinants of health attribute only partly to the health system, we come into a really uncomfortable question for at least the two of us, because is it really the health budget that we should discuss, or is it maybe other budgets too, particularly when we come to prevention, education, health literacy, etc. So sometimes we do have an issue there, and this is a quite uncomfortable question, so I would prefer not to go further than that in my capacity here. But in including patients, I think the main topic will be then that we need to make sure that the people contributing to the welfare state are also happy with it, and that they understand the choices that we have to make. Because I agree, if we don't make choices, we do only have, if we don't make implicit choices, we have explicit choices because of restrictions that we will always face. Yeah? So no budget will be fit for purpose in an ideal world, because we need to have this differentiation, and we need to get better so that we understand health also as a key ingredient for social and economic growth, because otherwise it's impossible. At the same time, we were in the beginning adding up the numbers that we could save in health, and then came to a negative sum. So actually we would gain money from the health system, and obviously that will never happen, right? So the question is, we need to have this social participation. That was the first strong point. Also making sure that the priorities are right for the people contributing to the health system. And I think there we need to get better, because it's about priorities.
Thank you. Yes, and a point about Sir Michael Marmot's work on social determinants of health. But Pedro, what about for you? What are the issues that were raised? What strikes you most?
There were so many things raised and all interesting. I would maybe like to come back. It's clear that other sectors like housing or air quality, water quality, etc., as a payer, I could say a lot of the costs I see in healthcare expenditure is also caused by these elements, and we want to tackle that. But of course, it would be good that within the healthcare systems and in my institution and in the consultation model, we already do within our system what needs to be done. I mean, like my healthcare budget in Belgium, I have the sector of the doctors, I have the sector of the medicines, I have the sectors of the home nurses, I have the sector of the hospitals, and they all have their own budget. They consider it as a sort of acquis. It's our right to deal with that. But if we want to talk about mental health care, for example, and what we did the last few years, we know in Belgium, for example, that a lot of people are using antidepressants, etc. So we invested a lot in primary mental health care, and obviously our expectation is also that this will help to diminish the number of people using for a long time medicines for antidepressants, etc. So we should already do this within our own healthcare system before we start to negotiate with other sectors to say, well, you also need to contribute. We need to start working together within the healthcare budget too. I do not really agree. It's true that we have an annual budget. That's just the rules of the budget. But this said, for example, we in Belgium, for the moment, we are having negotiations for a new federal government. Obviously, there's a pluriannual budgetary trajectory where also healthcare has a certain evolution that will be guaranteed or more or less guaranteed, and our healthcare system needs to adapt to it and see how could we invest more in the beginning and then maybe have a sort of a return on it later on. So there are possibilities to kind of have a pluriannual perspective, but it's within the limits, of course, of the budget. The fiscal pressure won't increase in Europe. It's at the top in many countries. We won't tax the people even more. We had a discussion in OECD. There's no political or societal will to do that. The part of health within the total public expenditure probably won't grow a lot either, since we have competing dossiers elsewhere. So it's really within that budget. Let's be realistic. We need to do better with existing expenditure, and then the margins that are liberated, that we can use for investing in new innovations, not only medicines or technologies, certainly also, but also new service models, and this would be important.
Thank you. But prevention then is absolutely key. But Natalie, your industry would be out of a job, wouldn't it, if prevention were actually perfected in the way that we'd all like to see? You'd have nothing to do.
Well, actually, we do a lot of prevention. So that's. I was going to use your mental health case because two of my, maybe three, are benefiting from completely free psychological support. That is unbelievable for a teenager or a young person, and it will make a huge. So hats off. There are lots of countries who I think are very jealous of your situation. No, well, in EFPIA we also have vaccines. So my bad for not communicating that to the first question. I didn't say prevention is all over my notes, so I clearly have a problem. But the idea of healthcare is to go from prevention to care to cure. Ideally, also with cure, we wouldn't have a job anymore if we managed to cure everything. So I think the objective here, and the problem is we were only on the panel for 20 minutes before we got the questions, and obviously we haven't said anything. And the other frustration would be on the panel is that we won't be able to say everything. So I hope that there are moments when we can speak outside, but there was a question that I don't want to ignore about you need investment to get data, but then you need data to get investment. There are models where you incentivize putting data in. So I know that there are outcomes-based hospitals in Sweden where the outcome of the patient is what determines what everybody else gets in terms of having participated to that. So the data that you collect on the outcome of the patient will allow the doctor to be paid, the nurse to be paid, the hospital to be ranked, etc. So that, for me, is a super smart, another way of thinking that creates the incentives, because the incentives at the moment are all wrong. And prevention, I mean, we're all part of it together, but it brings us back again to the discussion that health is not just about health. If I'd gone for a longer walk this morning, I would probably be in a better health than if I hadn't. So I think there's personal responsibility, there's societal responsibility, and then there's an industry and a healthcare system there to try and take us on that pathway in which we are unfortunately all patients at one point.
Well, let's come to solutions then. And thank you so much for the points raised. Keep them coming online. Josephine is collating the key things, and we will come back to the room. But Joachim, picking up on what Natalie was saying there about incentives, in Sweden, are there some good examples about how incentives can actually help people or organizations take responsibility for public health?
It's they're quite weak, I would say, also in Sweden. There has been a lot of, efforts to try and look at, for example, there are we talk about this thing with siloed budget, so you know that you have an effect, you do, and you have an expenditure somewhere, and then the effects show up in some other budget. And that is one of the reasons why it's thought that a lot of preventive and lifestyle changes and things like that are so hard to achieve. And there has been, I mean, you could think, for example, that you could make transfers of money between different budgets to solve that issue. And that has been tried in Sweden, I think, with rather little success, unfortunately.
I'm just thinking also, did you not have an example of where they were fining some of the hospitals for not getting the elderly out?
Yeah, so that's one. Yeah, that's a good.
An organizational change.
Yes, thank you for reminding me of that, because that's a pretty good example where municipalities are responsible for bringing home elderly patients once they are finished in the hospital, and they keep them there for any number of days because it's cheaper for the municipality. So they like to mostly reduce the expenditures on their own budgets. And they have actually tried both solutions in that case. So there are some examples, a few, but they have changed they made an organizational change so that they put it both in the same budget. And that has worked quite well, actually, both for the elderly and also for psychiatric patients, where they could actually take care of them in their homes rather than in hospitals to a much greater extent, which was good. It's not I mean, it's good, but it's not fantastic. It doesn't solve all the problems. And they've also tried to put very heavy fines on the municipalities for not bringing their patients home. And but that becomes a very simple economic calculation for the municipalities. And so that didn't work so well either. I think the best examples are actually when they had the municipalities put a person actually working inside the hospital at all times and working alongside the doctors and preparing the municipality for when the patient is ready to go home.
Thank you.
There needs to be a plan for what will happen to that patient. And that has actually been that worked much better, and I think that points to the bigger issue of governance, which we might talk about later, with very serious problems with communication between different levels of healthcare and social services.
And Julia, I'm wondering about in diabetes, do you have examples of innovative funding models that can help? Because we're looking to try and find solutions, best practice.
So not so much about the funding, but at least about data. And here in Sweden, for example, we do have very good registries that are national registries where we do have data about medication, where we do have data about complications, and all individuals with diabetes are included into that registry. And also we can get access within projects to these data to analyze. So that's something where, at least as a community, we have some incentives to use these data sets. Unfortunately, many countries do not have such registries. So for example, Austria does not have like a centralized diabetes registry. There is one established for Austria, Germany and Switzerland together with Luxembourg, but that's paid by the investigators, so that's paid by the universities, and that's out of scientific interest. And I think that should be something considered more on a European perspective, where we have a joint European registry about diabetes so that we get better data and can provide similar care all across the different countries.
Yes, thank you. And Stefan, I'm wondering from a national perspective, it was touched on earlier, this conflict between, it is in effect all one budget, and as was raised, health should be a factor in all considerations for whichever department, and yet you need to break it down into silos, for want of a better word, and health budgets where people take responsibility. So on a national level, how do you square that circle? Do you see all expenditure on health as an investment, or what's needed to actually make the case for more investment and clearer visibility of what's going on there?
I want to give 3 examples because making it a bit more practical, right, and concrete. The first one is in the current healthcare reform, where it is not about simply more money. I think this is where we can all agree. and at least in the countries represented here. I think this is definitely a case for many other countries, but the OECD had also a nice study of the resilience, that obviously it needs more money, but it needs very focused new money, and this is also a number of publications from the observatory. So what we introduced now in the current healthcare reform was substantial additional money, but linked to structural reforms. Now we got the criticism, it was the linkage was not strong enough, etc. But I think that is exactly the question. We just it was a simple solution in previous years to throw money at problems. But it won't work. Well, it never worked really well, because actually it's not what is needed. It's the process. It's so many other things, but not purely the money typically. And it won't work because we simply will not have the money. So what we did was in this healthcare reform really trying to make sure the structural reform showing and demonstrating the cost of inaction. So really looking at, if we don't change, we know demography will change, etc. So there will be an additional burden, and we need to address that. So really on making financial space and the possibility to maneuver for structural reforms. But then it's so hard to implement those, it's even harder if you don't have money. The second example, we know that there are certain areas in our healthcare systems. One is definitely prevention, one is primary healthcare in most cases, where actually every additional euro is well spent, typically. So there is actually not much need to look into, but really to make sure that, and again, we have a problem with silo budgets, because it's the outpatient that does more, delivers more, and maybe we can reduce hospitalization rates. So we do have an issue there, and that might be, again, the incentive why it's not happening. So we pushed massively on expanding primary healthcare in Austria, and also with additional EU funding in the RF as the biggest project in healthcare, and that really helped in being quicker in rolling out primary healthcare. And the last example, and this is why we think, and I agree, Natalie, you said it, there is a role for the EU. There are so many EU funding instruments outside health, also inside health, but particularly outside. And we will also need to protect the investments, for example, to adapt to climate change, etc. Because otherwise, we know that we focus very often on the running cost, and then we skip the investments, because the running cost is just the more pressing issue that we have to deal with every day. So we think that this additional use of EU money, particularly for the health sector, and again, it's about health and climate. It's not one or the other. It's really combining it, for example, with climate and also in other areas, that we want to be better in using those funds and make sure that we raise the importance of public health in Europe with that.
Thank you. And then Pedro in Belgium, how do you see what was touched on there about structural aligning of budgets? How important is that to see this bigger picture and put the case for greater investment and better focused use of the money that's there?
It's obviously it's not easy. I think that last few years what we have seen is to, for example, have more multidisciplinary care pathways. Very important for chronic conditions, for example. What we have been doing is using part of the new fresh money, because we get each year a certain growth norm and real growth on the healthcare budget. We didn't automatically disperse it over all the sectoral budgets. We put it in a transversal budget line, and what we did is in fact say to all the included healthcare providers, make a care pathway and design something new rather than giving each one his piece. What we see is that it's really hard, and that these care pathways, it's hard to design them with the healthcare providers, and when we implement them, the take-up is also slow. But that's a way we try to kind of force the sectors to work together and to leave behind a little bit the sectoral approach. So that's probably one of the things we are trying to do. I think we have a big reform, as many countries in the health, in the hospital sector. And I really do think that making the hospital sector and the landscape of hospitals much more efficient, this reform, which is really hard, should be coupled to a real budgetary trajectory. And there has been a lot of discussion on it. If we can, for example, say today we are at point X for the expenditure for the current hospital capacity, if we would be able to make it more efficient, and it means consolidated because we have an offer that's way too big and not efficient at all, then maybe in 5 years we should be able to diminish it to that point. And the margin that comes free at that point, we could invest it in strengthening primary care. I don't agree, by the way, that every penny spent in primary care is a penny well spent, because I think, honestly, that the primary care system is extremely fragmented and not efficient at all.
Joachim, you wanted to come in on that?
Yeah, I think this. So I've been doing a lot of work on this thing with, making sure that budgets communicate and stuff like that. And then, but over the past few years, I'm starting to think that those solutions, it's too complex, too complicated, usually doesn't work very well. And then I'm, looking at other sectors, like for example, schools, education, infrastructure, they have enormous effects in other sectors of society and over very long time periods. They affect health, for example, to a very large extent, and no transfers needed. You taxpayers pay tax, someone gets the job of having a good school, and then they do it. You don't need to transfer money from healthcare to schools to make the schools open every morning and things like that. It doesn't have to be that complicated, but I think it needs to be someone's job in healthcare or in society to keep people healthy. It's no one's job right now.
Oh, it's all our jobs.
If it's everyone's job, it's no one's job.
Yes. Natalie, on that, when you were talking about the work that you do in prevention as well as in treatment and cures, when new medicines come on board, they can be quite costly. So we're talking about restrained budgets in a difficult climate, geopolitically and in budgetary terms. Who should pay for that? Can the industry be part of that solution?
Thanks, Sue, because these are important questions, and they come up all the time. And it's clear that just as we don't all have individual responsibilities in terms of paying, we also have to share that responsibility. And I'd argue that we're already all paying for those diseases. I mean, our healthcare systems have been paying for chronic diseases for a long time, especially the ones without solutions. If you think about Alzheimer's or obesity, diabetes a bit better because there are some solutions. And enormously, they've been paying in prevention, primary care, they've been paying in hospitals, in ERs, in rehabilitation, so that there is a huge expenditure going on. The question is, how can you make sure that we together invest in solutions that will reduce that cost, knowing that the budgets are siloed? Because I've heard, this is helpful, I've heard they are siloed, forget about it. Okay. But that's, maybe they won't be, and Pedro, you're trying some new things, like we'll give you a transversal budget, and you might get it if you work in a non-siloed way. I love that, because maybe I've been naive over the last 7.5 years. Can you not just sit together and work on not having it siloed? So it sounds like you can't do that, but if you create an incentive to not be siloed with the money at the end, maybe we can do that. So as an industry, we do our part with novel payment mechanisms, with Netflix subscription. We try and do what we can do on our own with these new treatments that sometimes, the result is seen later. So you want to make sure that you're paying for the right thing at the right moment and not up front. But we can't do things on our own. So I do know that we have to work together with the finance ministers and all the other ministers. Skills for me is a huge issue. And you're talking about schools, but I'm also thinking about skills of the nurses and doctors that will have to cope with the new innovation. So it's not just about paying for the medicine. I think it's paying for the healthcare system upgrade to be able to use that medicine and then have that incentives for the silos to work together so that the savings and what we were talking about, the wastage on one side, can help to support the innovation in other parts, because medicines are not the only solution, of course. But I've learned so much this morning.
Well, we're all learning, and I want to hear from the floor again, and then if Josephine collates the best themes that are coming through. If a microphone could come to the front here, please. Do we have a microphone? And when one arrives, if you'd like to stand up and say who you are, and put your question. We'll take a few from the floor and a few from Josephine again and see what the panel might like to tackle.
Yeah, Alexander Rödiger. I'm heading oncology policy at MSD, and I would not be so pessimistic as the panel was this morning, because I mean, we heard in other conversations that life expectancy is increasing. So demographic change has a little bit two sides, I would say, from a societal perspective. The other, since I'm working a lot in oncology, also what we have seen in cancer, these developments are amazing. In some areas, you can really say that some patients can expect to live longer. The word investment, I was struggling a little bit, and to me it sounded a little bit like jumping to the conclusion, because it means also that we get profits at the end, but in the end what we are doing is avoiding the cost of doing nothing. But building on the finance sector, my question is, what are the mechanisms which lead to an improvement? We have Europe's Beating Cancer Plan, for example. So there are these visionary projects, but how can we make sure that they are implemented so that these targets are met? And one thing that we have been discussing earlier was, for example, to have a European health data into the European semester, so that you track the progress, so that you have a certain alignment on where you invest or where you spend the money. So I was just wondering what the panel thinks about this idea.
Thank you. There's a lot in there. Thank you. Any other questions in the room? Gentleman over there.
Just
who are you, please?
Yes, I'm Alberto Solos. I'm from Szemvesz Medical University in Budapest. I'm also running the communications for the JACARD Joint Action on cardiovascular disease and diabetes. We also work together with the Prevent NCDs Joint Action. These have over 60 million euros budget, so really big projects. And just one comment. My grandfather was a doctor, and he wrote an article in 1936 that he hopes that in the future doctors will focus on prevention. And so there is a debate which has been going on for over 100 years. So this would be my comment.
Thank you. And I think there was one more here, gentleman in the middle. Then we'll take a couple of points from online.
Yes. Yes, good morning. Richard Bergström. IQVIA, actually building on the same comment. Language is very important, particularly when we in this this community, when we talk to ministers of finance and others, because there's a notion that prevention is everything but medicines. Maybe vaccines, Natalie, okay? But most of the medicines, I would say the vast majority of medicines we use in volume, particularly all the cheap generics, it's prevention. It's just that we give people a diagnosis code. This is the fallacy of giving people a code. You have high blood pressure, that's a disease. Why are you giving them these medicines? It's to avoid something else. It's prevention. Statins, wonderful medicines that we introduced broadly. You know, even hepatitis C, I would say. We say it's a cure, but have someone having hepatitis C, no symptoms, nothing. You give a drug. Why do you give that? You prevent liver cirrhosis, transplantation, death. And now obesity, of course, the ultimate one, which is the big one right now. Yes, you say something, you're overweight, that's a disease. You need to take this medicine. That's the reason you take the medicines, because you want to prevent something, right? So I think we need to be much more sophisticated and thoughtful when we use the term prevention, because most of the medicines we have are preventing other stuff and problems.
Excellent point, thank you. Josephine, what are a couple of the top two on coming in online?
Thanks, Sue. So two of the main questions that have come in during the conversation are, first of all, ill health impacts political participation, sending people to the populist parties. According to your health observatory reports, how can systems improve on trust if they do not invest in healthcare? Second question, to implement any measure, a majority is needed, which usually cannot be achieved for a set of reasons. Therefore, it seems that our decision systems are not designed to implement any kind of meaningful change. How do we tackle this problem as a society?
Well, there's a little easy one as we come towards the end. I'm going to ask you all to be really, really brief, because I want to come to you all for a final comment as well. So incredibly quickly, Easy last question, Pedro.
We need more power for the civil servants, of course.
Okay, next. That's a nice short
But
answer.
It's a very fair point. You have seen that health systems, they have been built through consultation models that were really good in spending the extra money and building a system when there was a lot of money. The consultation models we work in today have a lot of issues to do the reforms needed and to function in a context of budgets under pressure. It's a fair point. I would like to react maybe to one point on prevention.
Very quickly.
Very quickly. We don't have to reinvent it. We have primary prevention, we have secondary, tertiary, and already that would clean up a little bit of discussion we had. But of course, giving statins or giving PPIs to patients, we could also give them better lifestyles, and then we are really in the primary prevention, and it's specifically there that so much could be done that would lower the costs in healthy lifestyles, and working on that for diabetes, for obesity, for mental health care, for so many things we could do better.
Thank you. I will ask you to be fairly brief, please. Stefan, what would you want to pick up on?
Now, because I also want to touch on prevention and the differentiation, but I want to focus on the trust question. I don't think it's about that we have to invest more money to gain the trust or to keep the trust. It's about being there when the health system is needed. And for that, I think we need the trust. And my concern is a bit that the trust, that we lose the trust a bit of being able to reform and to adapt, and not only vis-a-vis the population, but also vis-a-vis our finance colleagues, and also vis-a-vis the workforce and the stakeholders. So I think there's something we need to do together, because otherwise we don't get the structural reforms that we need through, and we need this trust.
Thank you. Julia, very quickly pick up one of those points.
Yeah, so I also wanted to focus on prevention. I think what we definitely need to jointly focus on is primary prevention to avoid going into secondary prevention and treatment.
Thank you. Joachim, very briefly, please.
Yeah, it's a lot of the secondary prevention is very cost effective, though, and a lot of the very early lifestyle changes are unknown or quite ineffective. And we have a huge issue with poor effectiveness.
But you've landed that one. Natalie, very briefly, picking up on any of those points.
I don't need to add anything.
Okay. Now, at the beginning, we saw in the video, it said, let's imagine a world where chronic diseases are alleviated by tackling them, and let's take action. So, very briefly, I want to ask each of my panel to say which one action they'd like. Now, just to help you, I've brought along my trusty crystal ball. So, I want you to look into this. And Natalie, I'm going to start with you. Don't you dare drop it. Solid crystal, it's quite heavy. One action that you would like to see, picking up on all the discussions we've had, what would you like to see taken first?
So that European, whatever we want to call it, beating NCD plan, I don't mind what it is, but a real focus on non-communicable diseases for the next 5 years.
Thank you. Pedro, what do you see in the crystal ball that you'd like to see taken first?
I need it for such a long time. I think that really, as a payer too, I really think that prevention, even if we are talking about it for 100 years, it should be on top of the agenda too. And we saw it in COVID, we see it all day long, so that would be my main wish.
Thank you. Stefan, looking into my crystal ball, what's the one action you can see being taken?
Thank you. Typically we say we don't have a crystal ball, and that's why we can't answer this question.
No.
So that's a tricky one now.
I'm lending you mine.
No, for me, and I was touching on that, it's really about keeping the solidarity in the system, and it was the social contract that was also discussed on this panel. And I think the discussion that we had and the priority setting that we said we need to focus will help us to strengthen solidarity again, and this social contract that we need for social welfare and economic growth.
Thank you. Julia, which one action do you like to see taken in the near future? What do you see?
So I think the most important part would be to have joint data space, so where we really have a joint data system across Europe, and then also have joint treatment plans, so that we do not leave some countries behind. or even some insurance companies. So if you are in Austria, you have a very fragmented system. So it depends how you are injured. Maybe you do not have the access to the same treatment as another person.
Okay, Joachim, careful with my crystal ball, please. Take a look.
Now I see it. I think we dearly need structural innovation, and we need to be much, much better at governing our healthcare systems. We need a new model away from the one that was outlined. And I think to do that, we need to start experimenting and do innovation, actually. And why not? I think maybe Sweden, with our good data, could be a good laboratory for maybe start doing like real proper European accountable care organizations who has a job to keep people out of hospitals and managing risk factors and so on.
Thank you. If I may take my crystal ball back.
No.
I am in command of the future. Thank you all in the room hugely for your attention, for your questions. Thank you to Josephine for collating everything from online. Thank you for everybody who's joined us online, or indeed might be watching on the replay. But most of all, thank you so much to this fantastic panel and to EFPIA for organising this session. It's been a fantastic discussion. Inevitably, there's so much more we now want to discuss from this, but the points you've raised have all been very, very important. Thank you all. Please join me in thanking our fabulous panel. Thank you.